Good evening, everyone, and welcome to tonight's GP Cancer Education webinar on colonoscopy, the full picture. My name is Helen Wilcox. I'm a GP from Shenton Park in Perth, and I sit on the GP Education project as part of the Cancer Council Western Australia. I'd first like to acknowledge the traditional owners of the land on which we all meet and pay respect to the elders past and present and emerging, and offer my acknowledgement and respect to other Aboriginal and Torres Strait Islanders who are present tonight. So we certainly encourage you to ask questions during tonight's presentations. You can submit them via the question and answer function at the bottom of your screen, and I'll feed them through to our presenter at a suitable time. We'll send you an online evaluation survey after the event. Please complete this, please, because it helps us work out how we can improve the educational events we provide for you. So giving us ideas about the format, of the style, or future topics you would like to see covered would be excellent. So I'd like to introduce tonight's guest speaker, Dr. Muna Salama. Muna is a consultant with over 10 years consultant experience in luminal adult gastroenterology and with a subspecialty interest in inflammatory bowel disease. And Muna undertook medical and specialty training here in Perth. She's got a mixed public and private practice between Sir Charles Gairdner Hospital, Osborne Park, for the public sector, and St John of God Subi and Hollywood Private Hospital for the private sector. Thanks very much for being available tonight, Muna, and over to you.
Thanks very much, Helen. So tonight's webinar, we're going to cover colonoscopy, the full picture. So just to go through what hopefully we'll get out of today's webinar, we're going to look at the efficacy of the immunochemical FOBT as a screening tool in average risk populations. We're going to go through guidelines concerning referrals for colonoscopy, look at the appropriate role for the use of surveillance colonoscopies in those patients aged 74 years or older, and understand the risks and benefits of the various colorectal cancer screening modalities that are available around WA and the world. Before we go through all those things, I just want to quickly recap what the difference between screening and surveillance is, because those terms do come up quite a lot in this topic. So when we talk about screening, we're talking about tests that are done in average risk populations to stratify people into higher and lower risks of disease. So we're looking at asymptomatic average risk people, and we're talking about identifying cases. So our example of a screening test is the fecal occult blood test that you're doing in an asymptomatic average risk person. When we talk about surveillance, it's the ongoing follow-up of people who've already been identified at increased risk of disease, and we're looking at prevention and control. So examples of a surveillance program would include people who've already been found to have polyps, people who've got a strong family history of bowel cancer, or people after a diagnosis of colorectal cancer. So we're looking at ongoing prevention and control of disease. So bowel cancer, colorectal cancer is one of the most common cancers affecting Australians. There's a lifetime risk in men of about 1 in 10, and for females 1 in 15. And it's the second biggest cancer killer in Australia after lung cancer. We'll just have a look at a few figures. So table 1 here shows that in terms of the commonly diagnosed cancers, colorectal cancer is the 4th most common, with approximately 15,494 cases diagnosed for 2020. And then in terms of deaths, we see that for mortality, it's the second highest cancer killer in Australia, with approximately 5,300 deaths from bowel cancer. If we look at the global picture for colorectal cancer, Australia has one of the highest incidence rates. These are age standardized incidence rates around the world. The color coding shows the incidence, and the darkest blue, so this is for males, the darkest blue indicates the highest incidence rates. And we can see that Australia and New Zealand fall into that band. The picture is very similar for females falling into the higher band, just slightly lower incidence rates than what we see for for males. So this table here from the WHO shows the incidences we've just said, and then looks at the mortality. So Australia and New Zealand have the second highest incidence rate around the world, second to Northern Europe. Our mortality comes in at about 4th. So in terms of bowel cancer, we know that it increases as age increases. And this is a figure that looks at the age-specific incidence rates of bowel cancer by sex around Australia. And so we've got males and females, and then all people in the dashed line. And we can see after 40 is when the numbers really start to increase, particularly after 50, and then especially after 60, we see the incidence rates increasing significantly. So we know that it's a common condition and it has high incidence, high mortality. So what's happened to the survival from bowel cancer after it's diagnosed over the years? This figure here shows what's happened to survival from 1987 to 91, right through to 2012 to 2016. And we can see that the actual survival rate once people have been diagnosed with bowel cancer has improved. So it's gone from about 54% to about 74% in more recent years. So even though the numbers are increasing, we are getting better survival once people are diagnosed with bowel cancer. In terms of the development of bowel cancers often occur from a precursor lesion. So in this figure here on the left, we see what we'll typically call a benign adenomatous polyp. And we remove all adenomatous polyps or sessile serrated polyps that we see, because we have no way of predicting which ones are going to progress to a more advanced lesion, and particularly to the bowel cancers. So although we remove them all, we know that only about 5% of polyps will become a cancer. And that sequence of going from having a benign adenoma through to a cancer occurs slowly in most people, except for the very high risk populations of Lynch syndrome. And that time frame is somewhere between 5 to 15 years of progression. So in terms of symptoms and signs, early bowel cancer unfortunately does not have very many symptoms at all. And symptoms tend to occur when bowel cancers either become large or when we've already got metastatic disease. Some of the symptoms that do occur are rectal bleeding, particularly with left-sided or distal cancers. People can present with symptoms of anemia. So if they've got a low hemoglobin, they may present with shortness of breath, tiredness, lethargy, those sorts of things. Change in bowel habit is a very non-specific symptom, and we'll see later in the talk that symptoms of constipation and diarrhea are actually very non-specific and relatively low yield symptoms. Other symptoms such as abdominal pain, weight loss and masses, really we're getting to much more advanced stage of disease if people have those symptoms. And we often talk, particularly with weight loss, often with metastatic disease by that stage. So this table here that we're looking at shows the probability of colorectal cancer for either individual or paired symptoms. So we can look, there's symptoms and test results at the top and then down the side. And this is the positive predictive value or the probability of having cancer based on either a single one or multiple of these presentations. So if we take, for example, rectal bleeding, if we have a single episode of rectal bleeding, there's a 2.4% chance of that having a presentation of bowel cancer. However, if we have repeated episodes of rectal bleeding, that goes up to 6.8. The figures in the numbers in the red boxes that we can see have a yield of a more than 5% probability of cancer, whereas the white ones are less than 1% probability. So other high risk symptoms may be a presentation with rectal bleeding and an abnormal rectal examination. And abnormal rectal examination, obviously, as you would expect, does tend to have very high yield of having significant pathology. Whereas if we look at some of the lower yield symptoms, constipation, even as a repeat presentation, so multiple presentations with constipation, is still very low yield. So what are the low risk symptoms then? So young patients who've got abdominal bloating, often we don't find any significant pathology at all. We're often dealing with IBS and functional symptoms. Chronic constipation, as we've seen, tends to have very low yield. When we're doing colonoscopies at surveillance intervals that are too early as well, the yield tends to be quite low. So that's, for example, someone who's had a colonoscopy, they've been recommended to have a 5-year follow-up, for example, and instead we're doing one at 2 or 3 years. We know the chance of actually finding pathology is very low. If we're doing colonoscopies routinely with a weak family history, then the yield also is low. So that's in people who don't have first-degree relatives, where the members haven't been diagnosed at a young age, or there's only a few members of the family. And as I said, previous colonoscopy in the last 5 years. So we know that symptomatic presentation is late, and the question really is, what's the best way to find bowel cancer early? It is an ideal test for screening because we know it's common, it's asymptomatic in its early phases. If we find it early, we can simplify treatment, and if we find it early, we can improve outcomes and survival. And there are multiple randomized control trials to show that screening with different modalities does save lives. So let's have a look at what the options are in terms of screening tests that are available. So obviously Australia has adopted the immunochemical FOBT through the National Bowel Cancer Screening Program, and we'll go through that in more detail. In terms of other tests that are around and that have been looked at, the things that have been looked at and are done in various other places are flexible sigmoidoscopy. CT colonography is not routinely used as a screening test, but I'll just mention it, and then colonoscopy. So flexible sigmoidoscopy, the data have been a little bit conflicting. Initial studies showed that there was survival benefit in using flexible sigmoidoscopy as a screening tool, and a meta-analysis has shown that there's a reduction in the incidence of bowel cancer and only a trend towards a reduction in mortality. Obviously, if a flexible sigmoidoscopy is done and there's significant pathology, then people are going to have to then go on to have a colonoscopy anyway. A virtual colonoscopy tends to be done usually in patients who we think are not going to tolerate an anaesthetic, for example, or sedation. It does still require people to have bowel preparation, and if an abnormality is detected, then the recommendation would normally be to then go on to have a colonoscopy. So it's not an ideal screening test. However, it does have a very high rate of adenoma detection, and it's the best adenoma detector after colonoscopy. So in terms of yield, it has high yield, but not ideal as a screening test. Colonoscopy is actually used as a screening modality in the United States, and they adopt it as a 10-year screening tool. That's based on population-based studies alone. At the moment, there are no randomized control trials to show that colonoscopy used as a screening tool reduces mortality. It's only been in population-based studies. There are RCTs that are underway, but at the moment, that's not what the evidence shows. So obviously it's a much more expensive screening modality, and our health systems are incredibly different, and the number of procedures needed to do is much higher. So if we then look at the FOBT, just one other point is whenever we talk about a screening tool, the other thing that we have to think about are what are the risks of screening. So all of our screening tests, essentially, if they have an abnormality, will go on to have a colonoscopy if we're not using colonoscopy as the screening tool. So we come down to the risks of colonoscopy, and the risks are actually low. And in a meta-analysis of over 335,000 people who were screened with either an FOBT or a sigmoidoscopy who then went on to have a colonoscopy, there was only a major complication in 0.08% of people. And if we then look at only the FOBT group, that risk was even lower at 0.03%. And so although we often quote a complication rate of colonoscopy of 1 in 1,000, in practice, it's probably significantly lower than that. In terms of the other screening modalities, so for CT, obviously the other risks, as I mentioned, you still have to have the bowel preparation. So there's the potential risks of bowel preparation and your exposure to radiation. Sigmoidoscopy, the appeal of that is that it's relatively safe. The only bowel preparation is an enema to have the procedure. And in many places around the world, it's done awake, although that's not often the practice in West Australia. So this is the fecal occult blood test kit that patients get sent as part of the National Bowel Cancer Program. It's sent to their house. They can do it at home. They send it back. It's easy, or not necessarily appealing. It's easy and can be done in the comfort of their own house. So it has, it fulfills many of the criteria of a good screening test. It can be sent remotely to people so that we're trying to provide it to as wide the population as we can. So in terms of the fecal occult blood test, if we look at the sensitivity, which is those people with disease who get a positive test, it's certainly not 100%, but it's high. It's 83%. So that means if there's a cancer there, 83% of cancers will be found. And we know that if we repeat testing, then that increases the sensitivity, which is the reason for the 2-yearly FOBT. In terms of what the yield of a positive test is, so of the positive predictive value, so that's a positive test ending up having a cancer, it's about 5%, really 3 to 5% of positive FOBTs will have a cancer. So what that means is a positive test has a much higher chance of yielding bowel cancer than a negative test, and it results in much more efficient use of colonoscopy. But also importantly, and it's important to discuss this with patients, a positive test does not equal cancer. And in fact, the majority of people who have a positive test will not in fact have cancer. About 50% of people with a positive test will have pathology. And in that, we're talking adenomas and advanced lesions or other pathology. But many people will just have hemorrhoids or benign pathology and often a normal colonoscopy. So the program is conducted as a 2-yearly screening from 50 to 74-year-olds. It's completed now, so all age groups are participating. In 2018 to 19, there was approximately a 44% participation rate, and participation slightly higher in females. So it was about 46% in females and about 42% in males. Of people who participated, 7% of the participants got a positive result, and of those positive results in that year period, 3% of those that were positive were found to have cancer. Melinda, I might just stop there. Are you happy there's no questions at this stage? And Helen?
I haven't seen any questions come through, but I'm going to be cheeky and ask one of my own.
Sure.
You've spoken to us about risks of colonoscopy for patients who have had an abnormal sigmoidoscopy and FOBT. I guess, could you make any comment on risks of colonoscopy for patients with the common symptoms?
I think they're equivalent. So, I mean, other than in your elderly patients, the risk of colonoscopy is in experienced hands is actually very low. As I said, most people would quote a significant complication rate of 1 in 1,000, and significant complication, we're often talking perforation. But as I said, the reality is that the actual complication rate is significantly lower than that. And, my personal perforation rate is much, much lower than 1 in 1,000. So overall, colonoscopy in experienced hands is a safe procedure. And, in terms of other complications other than perforation, the things that are more common tend to be post-polypectomy bleeding. And that depends on what we find, how big the polyp is, how it's removed, all those sorts of things. But in terms of serious complications, the risks are very low.
That's marvellous, and I think that reflects most of the patients majority of patients we see in general practice who we are referring for colonoscopy will be of that kind of overall background health. I don't think we would be referring you to the patients that needed urgent colonoscopies for large-scale bleeding, who'd obviously have higher morbidity attached and higher complication rates.
Yeah. I mean, the higher complication rates really come in patients over 75 years old, and I'll have a chat about that towards the end of the presentation. And that's for a number of reasons. It's not just the procedure, it's also more to do with bowel preparation. Really common things like someone will have bowel preparation, be rushing to the toilet, fall over, break a hip, they're old, end up with complications. So it's those sorts of other complications that can occur other than just the procedure itself.
All right, that's marvellous. Thank you so much.
Okay. So feel free to send through questions. It's I much prefer a face-to-face discussion where I can see people, but this is what we have today. So feel free to send them through to Helen, and I'm happy to try to answer as we go. So in terms of the National Bowel Cancer Screening Program and lives being saved, it's been estimated that by 2040, the National Bowel Cancer Screening Program will prevent approximately 92,200 cases of colorectal cancer and 59,000 cases of deaths. And that's based on a participation rate of just 40%. We also know that participants of the National Bowel Cancer Program have better outcomes in terms of the timing of their disease progression and the timing of finding it. So we're finding the cancers earlier. So for cancers that were found in participants of the National Bowel Cancer Program, 40% of those were found at stage 1 compared to 20% in non-participants. And stage 4 cancers were found in 3% versus the 12% in non-participants of the program. So there's definitely been proven to be a mortality reduction in screen detected cancers. And it's thought to be about 15% after correcting for lead time bias. So really what it comes down to is encouraging participation. And the higher the participation rates, the better the outcome will be from the program.
Could I ask a quick question, Myrna? Just to recap on some of the stats you talked about before, you mentioned about 5% of patients presenting with PR bleeding will be found to have an underlying cancer, but only 3% of patients with a positive FOBT will be diagnosed with cancer. Did we catch that right?
Repeated presentations.
Repeated presentations.
So if you have recurrent presentations, so definitely a one-off presentation of PR bleeding, your yield is not going to be that high. And that's why when I go through later in terms of the referral guidelines, we're talking about repeat presentations. We certainly get a lot of referrals for colonoscopy for a single or 2 episodes of very outlet type bleeding, and the yield there is much less than someone who's had 4 weeks of darker blood mixed in with their stool occurring on a repeat basis.
So this is a common general practice question that's been sent in. We frequently encounter patients that have a positive FOBT, who we then duly refer for colonoscopy, and they're found to have hemorrhoids alone. It's then difficult to determine whether they should have whether and when they should have future FOBTs done, knowing the risk of false positives. How do you approach that?
So the recommendation is after a colonoscopy, your next FOBT shouldn't be done for 4 years.
Okay.
So,
okay.
And even if, and I'll go through this, even if in our very low yield, so if you were to have 1 or 2 polyps, we now are recommending 10 yearly surveillance intervals for the next colonoscopy, but people can be offered an FOBT at 4 years. But don't go back to doing the FOBT at the two-year mark, because we will be getting positives, obviously, if they've got hemorrhoids or other pathology like that.
All right, that's very helpful. Thank you.
No, that's okay. So the only issue is that we also know there is a missed cancer rate. So what I would say is, if you have someone who you are worried about who has repeat presentations of PR bleeding or any symptoms that you're worried about, severe iron deficiency, anemia, even if they've had a colonoscopy in the last 5 years, if there's symptoms that are persisting and worrying to you, then it's appropriate to send them back to us for repeat colonoscopy, because we know that there's a missed cancer rate and no test is 100%, unfortunately, even colonoscopy. So don't feel that you can't refer back at all within that interval, because there certainly is pathology that's occasionally found. And there's also benign pathology such as inflammatory bowel disease, angiodysplasias, other pathology that can be managed depending on the presentation. So yeah, it's definitely not a hard and fast, don't refer back within a time interval. It's very much case by case. But if you have a completely normal colonoscopy and no other pathology other than maybe hemorrhoids or nothing, then the next FOBT should be at 4 years.
Great, thanks.
I did put this slide in, which I didn't really want to, but basically I just wanted to touch on what the potential impact of COVID has been on the National Bowel Cancer Screening Program. So this, it's very busy. It's looking at fortnightly intervals, and it looks at the number of kits that were analysed, the number of invitations that were sent, and the restriction periods. The first restriction period is highlighted in the shaded green section of A. And then this was when there was further lockdown measures applied, I think only in Victoria. And overall, what we're looking at is the number of cases between 2019 compared to 2020 for the same period, and whether there was a feeling that the COVID has had any effect on participation rates. And certainly it looks like in the start of the year, there was a significantly lower number of kits that were analysed, but there were also less invitations sent at the start of the year. And as the year progressed, the number of kits that were analysed increased compared to the same time in 2019. So the overall feeling was that it wasn't felt that COVID lockdown measures had really affected the overall participation in the program. It certainly has affected what we've been able to do with colonoscopies at various times, but overall that impact's likely to have been relatively low, given that the effects were only for short periods of time. So this figure here looks at the overall number of colonoscopies being done in Australia based on the states and territories from 1995 through to 2005, and the trend is likely to have continued. And we can see that over time, the number of procedures being done is increasing. We know that about 2/3 or more of procedures are done in private practice, with about 1/3 or less of those procedures being done in public practice. So of all the numbers, I think WA has about 100,000 colonoscopies being done per year. Less than 10% of those are for the indication of FOBT. So it's taking up a relatively low proportion of our procedures, which means that there's lots of procedures that are being done for relatively low yield indications. So in terms of the indications for referral, this is what I was speaking about before. There's general indications for referral, alarm symptoms, things that you should take more seriously, and then general risk factors. So the rectal bleeding, as we mentioned, not just a one-off episode particularly, but persistent rectal bleeding, especially if it's occurred for more than 4 weeks at a time. So positive FOBT obviously is a strong indication for referral for colonoscopy. Bloody diarrhea in the absence of an infective cause. A change of bowel habit for more than 6 weeks with alarm symptoms. And the alarm symptoms that we're talking about are bleeding, weight loss, severe pain, unexplained iron deficiency anemia, a mass, or bloody diarrhea. So they're all the things to take much more seriously. If you've got a change of bowel habit over the age of, for more than 6 weeks without alarm symptoms in someone over 60, that is a reasonable indication for referral. An unexplained iron deficiency anemia in men and non-menstruating women. A first episode of proven diverticulitis to exclude the malignancy, because some presentations of diverticulitis have got an underlying malignancy. If you've done a scan and it's shown an abnormality, then obviously that needs to be investigated further. Having said that, there's often thickened bowel seen on CT scans. That is just completely normal, just because of the way that CT scans are done. They're not done to look at the bowel. But definitely if it's recommended from a scan or some imaging to have a colonoscopy, then people should be referred for that. We obviously do a lot of procedures for the ongoing management of inflammatory bowel disease. And if there's any concern about your patients, then they should be referred to the specialist or referred directly for procedure. And then, as we spoke about, it's the surveillance for previous pathology. So people who've had a diagnosis of bowel cancer, where there's been polyps found in the past, or for surveillance for inflammatory bowel disease. And then we'll have a look at what constitutes a significant family history. So I guess the take home is it's significant symptoms that have persisted for more than 4 weeks on a regular basis. The presence of those alarm symptoms and more advanced age should be things that prompt you to refer on. So in terms of family history, it can be difficult to reassure patients and to tell them that all they need to have done is a FOBT. But I'm sure you all come across people who've got a parent in their 70s, for example, and they're concerned that their risk is high. But the reality is that if they've only got one family member who's over the age of 55, they're still classified as average risk. And in that group of people, the recommendation is to have FOBT from the age of 50. If you have someone who's got multiple family members, so what we're talking about is 2 first or second degree relatives on the same side of the family, or where the member of the family is a first degree relative under the age 55 or under, then that person should not be a participant in the FOBT program. So they are in a surveillance program because they're already identified as a high risk individual, and they should start to have colonoscopy every 5 years from the age of 50, or in people who have a young family member, it should be 10 years less than the youngest affected relative. If you've got patients who've got a serrated polyposis syndrome, then the recommendation is to, first of all, clear the bowel of the polyps, and that may take a few colonoscopies initially to do, and then to have colonoscopies every 2 years after they've had their bowel cleared. And in these high-risk syndromes, such as the sessile, there's the serrated polyposis syndrome, Lynch syndrome, and FAPs, you really should be getting advice from the specialist as to the surveillance intervals, because it really depends on the findings at the procedure for that. So our surveillance intervals have, the recommendations have changed recently, and it can be very confusing, and I would completely understand if it's gotten very confusing at a GP setting to understand what you should be doing and when you should be referring people back. The intervals have essentially been extended. So where we know that the follow-up colonoscopies after a polypectomy, the yield is low. So we've gone from saying that everyone at most should have a colonoscopy in 5 years to saying if someone has had a conventional adenoma with low-grade dysplasia and there was only 1 or 2 polyps, that we can extend that interval to 10 years. And that's where I was saying if you have someone in that group, they can be offered an FOBT at the 4-year mark, particularly if they're concerned, or if there's something. I mean, if there's something that worries you or symptoms, then they should be referred back anyway, rather than doing an FOBT. So if you've got someone with more advanced features, so even if there's only 1 or 2 polyps, if they've got high-grade dysplasia or villus features, then the interval will be 5 years. And then the other things that we look at is the number of polyps found. So for 3 to 4 polyps without any advanced features, we've gone to 5 yearly. If there's 5 to 9 polyps that we find, it's 3 yearly. And if there's 10 or more polyps at the index colonoscopy, we do a follow-up colonoscopy at a year. And so on. You can see that it depends on the number of polyps found at the time and what the histopathology findings are and the size of the polyps. To be honest, I would not have any expectation that at a GP level you should be able to be the person to recommend the surveillance interval. And I think it should be up to whoever's doing the colonoscopy to recommend the surveillance interval. The issue with that is that we don't have the histology at the time of doing the procedure. So we take the polyps off, but we can give a rough estimate as to whether we think it's going to be 3 yearly, 5 yearly, or a year based on the pathology that we find.
Nuna, can I jump in with just a comment and a question? And I'm keen to see if anyone wants to join me on the Q&A chat. Often, if patients have moved around, or if their old notes aren't available, or they've forgotten, the screening that they know that they were told to have a colonoscopy again at some stage, but they're not sure when. So personally, as a GP, I find that I am often needing to refer, determine the screening interval. The other instant, and I'm interested to see if people in the Q&A who have seen this, is patients who want it sooner than indicated. And so often it's good for us to be able to say, no, these are the current guidelines. It is safe to wait that long, but the recommendations have changed since you last had your colonoscopy X number of years ago.
Correct, and it hasn't only changed. The Medicare rebates are now restrictive. So to the point that, if you're out by a couple of months, you can't necessarily claim the rebate.
Right.
So there is, the caveat to that is, for, let's say, like you said, you have someone who's moved around, you don't have that original colonoscopy, you don't have the pathology. If you feel that surveillance is indicated, they can get a colonoscopy, but then from then on, it will be guided by the findings of that colonoscopy.
Yep. So a related question from the floor is, we don't seem to have a national colon cancer screening register like we do for cervical screening, or do we?
Say that again.
We have a good national cervical screening register.
Yeah.
Do we have an equivalent one for colon cancer, and how well does it function?
Well, I mean, I guess that are they talking about the National Bowel Cancer Program? Because they do follow up. So they follow up all the positive tests and will ensure that a positive test is recommended to have a colonoscopy, and then they'll follow up if that colonoscopy has been done and the pathology. So I mean, it is definitely, there is a register for it, and there's we have a team of people who run that.
Right. Another query to come from me, and I'm keen to see if people have also had this issue from the floor. It may be that the most recent colonoscopy someone's had was clear, no polyps at all, but previously they've had some degree of, they've had some kind of adenoma. Do we base colonoscopy screenings on the previous colonoscopies and the most recent one, or should prior colonoscopies inform the intervals at all?
So it's both. So if you have an adenoma, 5 years later you have another colonoscopy and it's clear, then you basically have two polyp-free colonoscopies to extend to a 10-year interval after having an adenoma.
Excellent, thank you.
Yeah, so it's a combination of both, and usually by that stage people are over 75, and we can stop doing surveillance colonoscopy. So it's difficult. It is difficult in younger patients, and that's probably the younger patients tend to have these sessile serrated polyps, and if there's one or two, let's say you've got a young patient with two sessile polyps and they're in their 30s, we are then looking at multiple colonoscopies in their lifetime. But if if you have two sets of colonoscopies that are free of polyps, you can extend the interval. Okay, so just in terms of the ongoing surveillance, the only other point on this slide that I was just going to touch on was what to do after bowel cancer diagnosis. So after having treatment for the colorectal cancer, people should have a complete examination of the colonoscopy a year after. If they've not had a complete colonoscopy, for example, if it was an obstructing tumour, then they should have it before or within 6 months of surgery. So then after they do one at 1 year, and then after that 1 year post-cancer colonoscopy, then you revert back to the table above. So those guidelines that I've just gone through are available online. So if you are stuck, you can easily look them up. But as I said, I think you should be getting some advice from whoever's doing the procedures. So what do we do about people that are over 75 or over? How do we decide who we should be having ongoing surveillance for in this population? And there's a well-validated score called the Charlson score, which indicates to you whether someone should have further colonoscopic surveillance or not. And really what the Charlson score gives you an idea of is that patient's life expectancy, I guess, or the mortality benefit. So it can give you an idea of whether to stratify someone to proceed with colonoscopy or not. And if the Charlson score is less than or equal to 4 and they're between the age of 75 to 80, then you can consider having a colonoscopy and discuss it with the patient. And if they're over 80, regardless of what their score is, then really a colonoscopy purely for polyp surveillance is not indicated. The only reason to be doing colonoscopies in people over the age of 80 is if they're symptomatic and you're worried about pathology, as opposed to ongoing polyp surveillance. And at any age, a score over 40, we would say not to recommend doing colonoscopy. And so the Charlson score is based on patient's age. So automatically, by being between 75 to 79, they get 3 points. And then you can only have 1 point for any of these conditions and you already get to 4. And so they can't have significant liver disease, diabetes with end organ damage, have had a hemiplegia, severe renal disease, AIDS, metastatic or non-metastatic malignancies. So any of those things automatically you're not, I mean, it makes sense not to be doing a colonoscopy. And then, as I said, over the age of 80, not to be doing it for polyp surveillance. So just very briefly, this wasn't one of the topics to cover, but just to say that there has been an increase in the incidence in bowel cancer in young patients over the years. And so since the mid-2000s, the incidence has increased by up to 9.3% per year. And there's a number of reasons potentially for that, such as obesity, alcohol intake, exercise levels, red and processed meat consumption. They're all things that are thought to factor into the increased incidence in the under 50 subgroup. So does that mean that people under the age of 50 should be included in the screening program? Well, it's not recommended as part of our population program because it does result in much less efficient use of resources. So one of the very first slides that I showed you about the incidence of bowel cancer as age increases, after 40 that it does start to go up, but really only starts to really increase after 50. So it results in much less efficient use of resources with significant increase in demands. So as part of the program, it's better to focus on people over the age of 50. But on an individual level, from 45 to 50 years of age, it's something that you can discuss doing with your patients, depending on the patient themselves. So it would be nice to be able to do a little bit of a case discussion and get some feedback. So I'll read out an example of a case and see what people think should happen. And Helen, maybe if you can feed through some answers and we can have a chat about it. If it doesn't work, then I'll just run through them.
I think that should work well. Go for it.
Okay. First case, if we've got a 65-year-old woman who's fit and active. She's had 6 weeks of increasing blood in her bowel motions. It's occurring on most days of the week, but she's otherwise completely well. She's not had any change in her bowels. She's healthy, eats lots of fruits and vegetables and exercises, and just has some mild hypertension and osteoarthritis. So in that situation, what would be the most appropriate next thing?
If people want to put their responses into the Q&A.
Can I see that? Okay. I think I can see that. Yeah, so I mean, people are saying colonoscopy and urgent referral, and that's correct. So someone who's symptomatic with bleeding should have a colonoscopy. So it's not infrequent that we'll have referrals that have said patients been symptomatic with bleeding, but people have gone on to do an FOBT. And that's just the point of that case, is if you've got someone who has bleeding, there is nothing to be gained by doing the fecal occult blood test. Okay. So second case, we've got a 50-year-old woman who's well. Her mother was diagnosed with bowel cancer at the age of 78. She is asymptomatic. Does she need a colonoscopy?
And when you say she's well, we'll take that as meaning no symptoms.
No symptoms. Yeah.
No previous colonoscopy. Completely new to the process.
Correct. Yeah. Anyone want to suggest what they would do? No scope, needs health promotion advice. Yep. And what if she says to you, I'm really worried though, I really want to have a colonoscopy. Is there anything we'd recommend? So health promotion advice, I guess we can surveillance candidate. reduced risk with good exercise, etc. Yes, that's true. What about if we recommended participation in the National Bowel Cancer Program? So that would be relevant, right? So her risk is slightly higher than average, but she is not high risk and shouldn't go automatically to colonoscopy. But you should encourage her to take part in the National Bowel Cancer Screening Program. So she's 50, so she should be having FOBT, and then can either be reassured with a negative result, or if it comes back positive, then she could go on and have a colonoscopy. If she had a family member, first degree relative under 55 or under, then of course, then we would recommend colonoscopy. So happy with that case?
Sounds good.
Yeah. So we've got a 60-year-old woman who's actually just been diagnosed with bowel cancer. She's shocked because she eats well, exercises, she's slim, doesn't smoke, doesn't drink any alcohol, has no family history. So the point here is just to, not everyone who gets diagnosed with bowel cancer is, unwell, has a strong family history, overweight, and all the rest of it. Of course, it does happen in low risk people. So the risk factors for bowel cancer are general. Had she participated in the National Bowel Cancer Program, it may have been picked up earlier, but there's no point bringing that up now. That often just leads to anxiety. So just, bear in mind there's no typical, the risk factors that we talk about are general. So no hard and fast there. So we've got a 40-year-old woman who's previously well. She's got 3 healthy children. She's got 3 months of feeling quite fatigued and breathless. You do some blood tests and notice that she's got an iron deficiency anemia with a hemoglobin of 10. She does have quite heavy periods and doesn't eat that much red meat. Do we think that bowel cancer is the cause of her iron deficiency anemia?
While people are answering, I'll just jump in and say that's an excellent case.
Yes.
And often these women aren't 40, often these women are 45 or 48 and they're having perimenopausal heavy menstrual bleeding, but they're just that little bit higher in age. And it can be really hard to tease it out. So interested to see what people think.
So Rosalie has said, yes, absolutely, should have, it could be bowel cancer. Try addressing the iron deficiency and perform FOBT. Manage her menorrhagia, then review. So yes, manage her menorrhagia, address the iron deficiency. But yes, the bowel cancer could be causing it. So let's say you addressed her menorrhagia, gave her an iron infusion, and she remained iron deficient. At that stage, I think most people would be comfortable to refer on. So yeah, the reality is it's probably not bowel cancer. It probably is related to menstrual loss and dietary intake. However, if despite iron replacement you don't have improvement, then people should be referred on for colonoscopy and gastroscopy. We would do both for an iron deficiency anemia. Colonoscopy.
I feel like I'm asking all the questions here, but I'm just considering that I'm speaking on behalf of the floor. So it's interesting that you have said intravenous best. And is this because in this particular example, we are looking for rapid improvement in iron stores, or sort of a controlled improvement in iron stores, as opposed to oral iron therapy, which for reasons of compliance or poor absorption might not give us the result we want in terms of being able to indicate whether there's ongoing blood loss? I'm just interested in why you said intravenous best.
Yeah, so I think there's a number of reasons. So one, once someone's significantly anemic, I guess you want to replete their stores faster. And if you are concerned that there's significant pathology, you probably don't want to wait the time to see if the oral iron replacement improves the iron deficiency. But that sentence also means that intravenous is best at repleting your stores. So I guess it really depends on your level of clinical concern. And if you are concerned that it's not just menstrual and maybe, the anemia is out of keeping to what you'd expect with that level of bleeding, then the best thing to do is to replace the iron quickly and then track what happens to the ferritin and the hemoglobin over the course of 1 to 2 months to decide whether they do need ongoing investigation. Does that make sense?
Yeah, I think that makes sense. And in practical terms, that often works well in general practice because that will give us perhaps time to have a colonoscopy appointment come up, especially if we're in the public system. And it may well give people time to, especially if she's a busy young mum, give her time to organise colonoscopy as well, because that might not be that straightforward.
Yeah. I mean, it's a completely different story if all we're dealing with is iron deficiency as opposed to iron deficiency anemia. I think if you've just got iron deficiency, I would say just go with oral replacement and, then look for the improvement. But if you've got someone who's anemic, then the yield and the risk of pathology is significantly higher. Okay, just go on to, this is one of the last questions. So we've got a 48-year-old woman who's been treated for CIN2. She's anxious and overweight and smokes. She's worried about bowel cancer happening at an earlier age. What would you recommend for someone like her at the age of 48?
So I think while people are formulating their answers, just to jump in, some people have said that this is happening at she had CIN2 at an early age, and some others have said just FOBT for her. Yeah. I suppose the difference is that she's had CIN2, which I guess would be a risk factor for anal cancer or perianal cancer as opposed to bowel cancer. But I think that's probably what you're going to tell us about.
Oh, not so much. I guess it's just that, it's in someone it could have been any malignancy. I guess once patients have a malignancy, I'm sure you guys deal with them being worried about all malignancies. And it's more to do with her age group is what I was saying. So she's not particularly higher risk of bowel cancer, but if she's anxious and at the age of 48, I think it would be completely reasonable to recommend doing an FOBT. Doing a colonoscopy is probably not appropriate, and support and counselling regarding healthy habits to reduce her overall risk would be appropriate. But I would recommend FOBT at that stage. Yeah, sorry, I wasn't going down the anal cancer. I think that's just a whole other topic. So I think that's probably the end of the cases there. So just to summarise what we've really gone through, bowel cancer is very common cancer, increases with older age, much of it's preventable, early diagnosis improves outcomes, target high risk symptoms and avoid over investigating low risk symptoms and encourage participation in the program. In terms of the colonoscopy use, prioritise based on high risk indications or FOBT positivity. So that's probably where we're at, unless there's some final questions. Let me try and see.
One question has come through around would she which of these patients, even though they're outside that 48-year-old who's outside the standard screening program, is she eligible for a Medicare rebatable FOBT?
I think no, I don't think Medicare rebatable. So that might be out of my, I don't know the answer to that. I don't know whether they'd have to just purchase it themselves. I mean, they certainly wouldn't be eligible for one through the program. But I don't actually know how they get a rebate, sorry.
And someone has said that Medicare specifically excludes screening. I'm not sure if that relates just, obviously, I guess that comment is made in regard to FOBT alone, as opposed to other screening programs.
Yeah, I'm not sure what that means.
Yes.
Yeah.
So, Muna, I think I'm not seeing any other questions come through. I'm seeing some words of thanks, and certainly on my part and on behalf of the Cancer Council this evening and all the attendees online, I'd like to thank you very much, Muna, for joining us this evening and sharing your insights on what's a topic that's highly relevant to GPs. It's a conversation that we would have we should be thinking of having with and checking up on all adult patients that we see. And it's clearly a space which has changed substantially in the last few years or so, so it's wonderful to be brought up to speed by your presentation. I'll thank everyone for joining us this evening, and for our Cancer Council team, Melinda, and also our support from Rebecca and Alex Cook. Remember, the evaluation forms are critically important for us to determine what you'd like us to put on next. And I look forward to seeing everybody at another Cancer Council event soon. Thanks and good night.